Just want to do a quick video, you know me, it actually won't be that quick, on inguinal hernias, a basic explanation of inguinal hernias. It's going to be a bit of flight of ideas from me because I just think there are certain things you need to know and they're going to come out in a weird order, but when you put all of these together I think you're going to understand things better. Okay. So what is a hernia? Well, we've all got an idea that a hernia is when something bulges out of something, right? That's kind of how we see a hernia. But the actual description of a hernia is a protrusion of a viscera, an organ, from its containing cavity or out of its containing cavity. So in the terms of inguinal hernias, we're actually talking about abdominal contents protruding through the abdominal wall. So whereabouts are these inguinal hernias actually happening? Well, I've got a picture of a pelvis here from Wikipedia, and I'm just going to draw on the left-hand side. So this is really the area we're talking about when we're talking about inguinal hernias. A few landmarks, I know you know these, but they're really important. So anterior superior iliac spine. Now, the attachment of the inguinal ligament is to the pubic tubercle, and this is the pubic tubercle here. Pubic tubercle, there. And then the inguinal ligament obviously goes between these two areas, so that's our inguinal ligament. Some people mistakenly sort of think about the pubic symphysis, so this is a joining of the pubic bones. This is also an important landmark, but it's not where the inguinal ligament attaches. So while we're talking a little bit about locations and terminologies, I just want to clear up a little thing, an anatomical term that we sometimes use, and it's the mid-inguinal point versus the mid-point of the inguinal ligament. These are not the same things, and I'll just show you why. So the mid-inguinal point is actually a point halfway between the anterior superior iliac spine and the pubic symphysis. So if I can get, so roughly about there, and right below there is the femoral artery, so it's a landmark for the femoral artery. The midpoint of the inguinal ligament is the midpoint of the inguinal ligament, which is slightly lateral to that, and is here. And this is a point above which the entrance to the inguinal canal, which we're going to talk about because that's very important in inguinal hernias. So the deep inguinal ring is actually the midpoint of the inguinal ligament. Okay, so they are different, they can't be used interchangeably because they have sort of two different points of reference. So something else that's really important in understanding inguinal hernias is the inguinal canal. The inguinal canal is an oblique, short passage that extends from inside the peritoneal cavity in males into the scrotum, in females into the labia majora. So this passage has a deep ring, so that's internal, and then a superficial ring, just lateral to the pubic tubercle, and then this is the passage down here. Remember we did that mid-inguinal point thing earlier, and we said that the femoral artery was just below it. Well, the thing about the femoral artery is that actually it was called the external iliac artery before it passed under the inguinal ligament, and the external iliac artery gives off a blood vessel called the inferior epigastric artery, and there's a vein there as well. So the inferior epigastric artery and vein are important landmarks as well. So just remember, we have this vessel going up here. I realise that all this seems a lot of random facts and not hanging together, but these will all come together, I hope, as this video progresses. So just very briefly, before we explain a few more things, what are the main inguinal hernias? Well, there's one called an indirect, so we have indirect and a direct. And I'm only going to briefly mention this, but basically, remember, a hernia is a protrusion of an organ out of its containing cavity, and so we can have, with an indirect hernia, we can have, say, a loop of bowel, just switching here, and that will enter the deep ring, go along here, and we're going to be talking about men mainly, because men are more likely to get these hernias. So this indirect inguinal hernia comes in the deep ring here, down the inguinal canal, and out the superficial ring, and in some cases into the scrotum here, so down into the scrotum. Direct inguinal hernia doesn't go into the inguinal canal, but pushes out of the anterior abdominal wall at around this point here. About indirect and direct, these are our main inguinal hernias that we're going to be talking about. But before we go on, you really need to understand why or how the inguinal canal came to be. So we need to talk a little bit about the embryology of the descent of the testes in terms of finding out how the inguinal canal came about. So we're looking at a side view, a sagittal section of the developing abdominal cavity, and remember that the testes develop para-aortically, sort of posterior abdominal wall. So if we're looking sort of roughly, if this is posterior and this is anterior here, our testes sort of start up here, and they're going to be making a descent down this way. This area here is the developing scrotum, and here, because we're using a male, it's a developing penis. So we've got to get this testicle down into the developing scrotum. So here we have our testicle, and it's descending, but remember that the trunk of the fetus is also sort of getting bigger. So in combination with sort of testes descending and the trunk of the fetus getting bigger, we actually get movement of the testicle down. So what structures are here? We've got something here called the gubernaculum, and this is a band of fibrous tissue that basically connects the posterior pole of the inferior pole of the testicle to the developing scrotum. And this band of tissue, the gubernaculum, actually condenses, gets shorter as the testicle descends, sort of guides the testicle down to where it needs to go. The testicle is also dragging its blood supply with it, so you get this kind of movement downwards. We also need to be aware of the different layers of the abdominal wall. So we've just got 3 layers here at the moment. We'll draw another one in. So the blue one is external oblique, the green one is internal oblique, and this purple stuff is transversalis fascia. And you may have noticed there's one missing, but actually in this region the transverse abdominis muscle doesn't come quite down as far, so we just put a little bit of muscle here. So transversus abdominis muscle doesn't come down so far. I'm just ignoring the skin and other fascial layers at the moment because they're not quite as important in what I'm trying to explain. Now we've also got the peritoneal cavity, and I've done a separate video on that, the developing peritoneal cavity. Just going to mark that here. And what I'm trying to show by this is that the testicle isn't actually in the peritoneal cavity, it's retroperitoneal, so retroperitoneal, and then sort of becomes infraperitoneal as it kind of descends. But just to say that this kind of grey blue blotch here is the peritoneal cavity, and a very important we get in the descent of the testes is an outpouching of the peritoneal cavity called the processus vaginalis. This processus vaginalis, this outpouching of the peritoneal cavity, actually sort of goes ahead of the descending testicle, and we'll see what happens next. So as the testicle descends and the scrotum develops, this processus vaginalis continues to kind of go ahead of the descending testicle here, and the gubernaculum here continues to condense and get shorter. We see that these layers, the external oblique, the internal oblique, and the transversalis fascia, start to kind of almost, you can sense them wrapping around the testicle. You get to a point where the testicle and the blood supply of the testicle and various other structures are sort of more or less surrounded. What happens then is this processus vaginalis, this outpouching of the peritoneum, actually then obliterates in this area here, leaving just this small amount of peritoneum covering an aspect of the testicle, and that is called the tunica vaginalis. So that's the remnant of the processus vaginalis, and then the peritoneal cavity sort of just sits up there. The gubernaculum sort of then becomes the scrotal ligament and just tethers the testicle down. The next thing I want to explain is, it's not difficult, but it's not entirely accurate, but it helps explain things. So you realise that the descent of the testes and the processus vaginalis and the gubernaculum are all forging away, almost pushing out through these layers of abdominal wall that I've just told you about, these muscles and their fascial components. If you can imagine these layers just coming sort of tight up towards the testicle and the blood supply and everything else, it helps explain how you get the various layers, say, of the spermatic cord. This innermost layer here, the purple layer, basically derived from transversalis fascia, becomes the internal spermatic fascia. The green layer, the next layer in, becomes the chromosteric fascia, which is derived from the internal oblique muscle, And the outermost layer, we've got this blue layer here, which is the deep fascia of the external oblique, becomes the external spermatic fascia. So the inguinal canal really is, if we can imagine this is more sort of wrapped up like a normal scrotum, is the connection between the peritoneal cavity and the scrotum, but actually not the whole way down to so peritoneal cavity to the scrotum, but you have to imagine that all these sort of layers are coming together. So the actual inguinal canal is not a very long sort of space, but it's the descent of the testes creates this pathway from the peritoneal cavity and in males into the scrotum. So what happens also if we get failure of the processus vaginalis to actually obliterate, so imagine that this is now just a connection here, we've now got effectively a peritoneal lined pathway from the peritoneal cavity into the scrotum, just that small section there, so that if we get sort of an intraperitoneal organ, like a bit of bowel, this is a loop of bowel, so loop of bowel, that can actually make its way down this way and in an indirect inguinal hernia pass through the inguinal canal and into the scrotum. And we'll talk about a little bit more about that later. Now this video has gone on way too long. I promised you a short video. So what I think I'm going to do is I'm going to call this part 1 and I'm going to do a part 2, and I hope that you'll watch part 2 and we'll see what happens.